Good evening, everybody, and welcome to a conversation between Dr. David Shiers and Dr. Jackie Curtis talking about collaboration in mental health, particularly regarding the care of people with early psychosis. This is presented by the Mental Health Professionals Network and the Themes Summer Forum, which is a first, and we're also doing this in the form of a podcast, which is a first for MHPN, so it's quite exciting. And we particularly welcome David to Australia. I'd just like to introduce you to David and Jackie to begin with. And many of you will know me from webinar facilitations before. My name's Mary Emilias, and I'm a GP in Cairns, and I work at a headspace, so I work with young people. Now, to introduce David, he's a GP from Leek in North Staffordshire in the UK. His special interest in mental health, arising from personal involvement as a carer, drove his commitment to improve the physical health care of those with serious and persisting mental disorders by leading a program of engagement between primary care and local early intervention services in the UK. David, I hope you've been enjoying your time in Australia so far.
It's a lot warmer than in England, for sure.
Yes, and it's been raining quite a bit too, I think. Or perhaps you came after the big rains.
I don't mind.
And welcome to Jackie. Jackie's a senior staff specialist in psychiatry in the South East Sydney Local Health District. Since 2002, she's worked with the Early Psychosis Program in Bondi, setting up a metabolic clinic in 2006. She's active in the education of mental health clinicians, GPs and non-government organisations in metabolic issues in mental health, and she recently co-chaired an international working group promoting physical health issues in youth with psychosis. Now, Jackie and David, I understand that you've actually worked together on some of these projects. Is that right?
We have. We first met in a conference in Amsterdam about just over 2 years ago. And I was just on the point of retirement, and my wife was worried about what I was going to do. But when I met Jackie, she was waving a physical health algorithm that I'd been trying to influence, the sort of thing I'd been trying to influence in England for several years without any success at all. So I took this back home to England, and the people I was working with, their eyes lit up. And it was quite clear that profits in your own land and all of that Jackie and Kathy, the two people involved in creating this resource, had created something very special, and I've spent the last 2 years trying to plagiarise and nick. So it's been a lovely relationship, and very grateful.
And I guess that indicates that a lot of the issues that people in primary care face, and indeed clients with mental illness face in the UK and in Australia, are quite similar. So there's been a real benefit from working together.
Yeah, absolutely.
Okay, and I've just realised I am sitting on a wheelie chair, and I'm going to try very hard not to keep moving. So apologies for the rudimentary technology in this webinar, but I hope the audience will forgive us. David has been working, and colleagues. I just wanted to read you a quote that came out of a focus group study of GP views, which was led by one of David's colleagues in the UK, Helen Lester. And it was written up in an article in the British Medical Journal in 2005. And I think this quote could equally have come from GPs in many places in Australia. And it says, "Sometimes they have to be standing on a bridge before we can get people help, and we have to exaggerate symptoms to get the psychiatrist's attention at an earlier stage." So I was just wondering if we could begin our discussion by looking at the role of primary care towards help seeking, and when young people have emerging psychosis or their families are beginning to get concerned, and primary care is trying to help them. So perhaps, David, you might start, and Jackie and David, you can discuss that.
Okay. Well, I guess some of the problems are that this is generally often a young group of people. People develop major mental illnesses often quite young, sort of adolescence and early adulthood, and they won't present in very classic sort of barn door sort of ways with delusions and hallucinations. It's often a very subtle process, and it's a relatively rare event. So as a GP, I might expect to see someone with an emerging psychotic illness perhaps once a year, maybe once every other year. It's not a particularly frequent event. And against that background, I'm also seeing a large number of young people coming up with psychological distresses and the challenges of young life, adolescent life, as they move on to adulthood. And we know that the less severe illnesses of anxiety and depression, they also start to sort of gather momentum quite significantly in the same age group. So the challenge for me as a GP is trying to distinguish what might be a less severe mental illness, which will probably start with sort of mild symptoms and then gather pace. So the sort of classic presentation of a major mental illness will be against this very sort of large background of people with distress. So that's a problem. From the young person's problem, it's actually quite scary coming to see a GP, even someone you might know from the past. So there's also that sense of trying to admit that you have a mental health problem to a health professional. My experience as a GP was that it was often the family that would sort of alert the problem, and it would typically be over a period of time. And I'd say that's one of the strengths of general practice, is that because we're in it for the long term, we often know families and we often know individuals well over a series of conversations that can run back years, that we're in a very strong position to begin to recognise when something isn't right, but we still have to be able to distinguish between the less severe and the more severe, bearing in mind it's a rare event. So that's my challenge, I think, as a GP. And the other issue, I think, is that if my intuition says to me there's something really not right, but I'm not able to articulate it, not certain of what's wrong, what I'm looking for then is some sort of place to give me advice, some person to give me advice, because I'm not certain. This classic sort of primary care issue. I have an uncertainty, I have a concern. Where do I take that to? Who do I take that to? Now, and so what I'm looking for is a specialist service that is happy to talk to me, happy to listen to me, happy to take a referral, where I'm not clear, I'm not absolutely certain what's wrong. My experience with a lot of mental health services is that you have to reach a threshold of illness, which means it's very difficult to refer someone or ask for advice to someone who hasn't reached that threshold. But to be told that your referral's inappropriate because it isn't clear at that stage is real. An inappropriate referral is almost an insult as a GP. I'm sure that you'd recognise that. But I'm looking for a service that's got a low threshold for taking my concerns.
And I guess one of the emphases of the Mental Health Professionals Network is it's multidisciplinary and it's collaborative. And I guess equally it might be a counselling social worker or a psychologist who's working with a young person over time who's come about distress, and they begin to notice symptoms that are concerning them, and they would equally like to have an accessible service with a low threshold. Jackie, I just was wondering, what you think. What is the ideal kind of service, and how does a psychiatrist fit into that?
Okay. Well, I guess all of the things that David say are true, that there's the low threshold and actually having a service that will be responsive to for anyone's concern, whether it be a general practitioner, a counsellor or any other allied health professional, is really important. And I suppose in Australia we've had a real shift over the years of this idea that you had to be really, really sick to enter mental health services, to reducing that threshold through the institution of these youth mental health types of models across the country. That's largely been led by the headspace developments, but also a recognition that young people present in this complex way where you can't always work out what's going on. And if you've got an appropriate youth-friendly service, then you just take on the concern and bring someone in and actually assess the person properly and well. So, for example, in the situation where I work, we have an early psychosis team, but we also have a youth mental health team, which takes exactly this kind of referral. So, very low threshold. Someone who wouldn't actually meet the criteria to enter the usual mental health services, but who the family or the GP or the school counsellor is concerned about. So, actually, just not using those, high risk usual thresholds is really important. And I think that being open to a multidisciplinary assessment is really important as well. So I think psychiatrists are just one part of that, but I do see a whole team approach to that. So whether you've got a counsellor who's concerned and thinks maybe I can get an expert advice and then might then send the person back to the counsellor or to, the general practitioner, you're still, I think, assessing and joining up together and taking all the concerns really seriously. I think education's really important here too, that I think we're becoming more aware across all the disciplines in mental health to actually ask the right questions. So in the past, maybe a young person who isn't overtly unwell with psychosis wouldn't have been asked about potential psychotic symptoms. They might present with depression or suicidal thoughts, and we may not have thought to ask. But I think there's an emerging trend now to recognise that any young person could be at risk of a more severe illness, and people are asking the right sorts of questions.
And I guess psychosis symptoms may be associated with a number of different disorders, and I suppose I understand that in some ways really you need a longitudinal view to know what's going to happen. So some people have psychosis symptoms which can resolve when the other stresses in their life resolve, and other people have symptoms which can continue relapsing and recurring over time. So is that the kind of view that the early psychosis team would have, to kind of observe someone over a period of time?
Yes, and hopefully both a specialist early psychosis service or else even a youth mental health service would allow for a comprehensive assessment, which would be over, could be over months. Because if someone, for example, I can think of young people who come in with what would look like a typical drug-induced psychosis, and you might think, oh, well, this is just because of the drugs they've used, and let's not worry about ongoing care. But often that's just a signal of something more that's evolving, and I think we find it's incredibly important to actually access that young person at that help-seeking moment and allow for as much engagement as you can with the young person and their families, and allow for whatever psychoeducation can go on and potential interventions ongoingly. So definitely actually looking at the cross-sectional picture is not enough. It has to be over some time. I think the other really critical point here is about engagement and a positive engagement. The worst scenario, I think, is what used to be the past experiences, which was a young person had to be really sick, and then they would be, their entry into the psychiatric services would be via the back of a police paddy wagon and into an involuntary admission. And of course that still occurs sometimes, but ideally, if a young person engages with a service in a more holistic and positive, engaging way, even if they're not that ill at that point, it actually helps them have a good experience of mental health and mental health services. And then later, if they do need more help, even if they don't want to engage with you in the beginning, they might come back again because they've had that positive experience up front. And certainly that's our experience. I'm sure with Headspace, Mary, and your experiences, it might be similar. You can't always get a young person to agree to come to you, but if you've had a good initial experience, then they're much more likely to come back. So I think that's where collaboration is really important too. So someone might be referred into a service by a private psychologist into a public mental health service. They might not want to come more than once or twice, and so really working closely with the referring person actually helps that young person with a pathway of care. It doesn't necessarily mean coming back to the mental health service, but the advice that you can give and the open door to come back again in the future is really important.
And I've noticed you've said a few times there that things like psychoeducation and working with families and looking at different, you referred to a number of different treatment modalities that might happen. So I guess perhaps, David, I know there's been a lot of concern from some GPs about early intervention focuses, that what might happen is that young people who were not necessarily going on to develop a longer-term psychotic illness can end up on really serious medications too quickly. And that's been a criticism, probably unnecessarily, but I know it's an anxiety about early detection and early intervention. Would you like to comment on that?
Yeah, sure. My experience has recently been informed because I've been in England we have a thing called the National Institute for Health and Clinical Excellence, and we do periodic reviews of guidance, and I've just come off being a GP advisor on the one on children and young people with psychosis and schizophrenia. So that's just been published a few weeks ago, and that was certainly one of the key issues that we talked about as a group, and then has been reflects in the publication. So the statement we made in this was that in people who actually who are possibly on the threshold of developing a psychosis, appear to be at very high risk of developing psychosis. And I'd look to someone like Jackie to be able to define that. From my point of view as a GP, I'm worried. This is a person who's showing symptoms and signs that do suggest that they're heading towards a major mental illness. But those people should not be given an antipsychotic medicine. However, what they should be given is support, and they should be given access to family interventions and CBT. So the evidence seems quite clear now that unless someone's got a definite psychotic illness, then actually giving them an antipsychotic medicine is a bad thing to do. And the reason it's a bad thing to do is that these are medicines that carry a huge amount of risk, particularly metabolic. The risk of metabolic complication is a real problem. And so to give a person who hasn't got a psychotic illness an antipsychotic medicine the balance doesn't make sense to me. And yet actually it's something that some of the research we looked at shocked me, because I was actually seeing evidence that children as young as 6 were being given antipsychotic medicines for conditions that were attention deficit and that sort of condition. So completely, without an indication, without a marketed indication, these children were being exposed to drugs which carried a high risk. So I feel very strongly about the use of antipsychotic medicines where there isn't a clear, where psychosis hasn't been diagnosed.
So David, I think I heard you say then that there's evidence that things like family intervention, psychoeducation, cognitive behaviour therapy are effective interventions for early psychosis, and in fact may lead to resolution of symptoms without you having to use antipsychotic medication. Did I hear that correctly?
No, you didn't exactly hear that.
Okay.
Sort of nuanced, really. There is evidence that in people who are at high risk of developing a psychosis, that if they're offered family interventions and CBT, then you will reduce the rate at which that group, the risk that group have of converting to having an absolute psychosis. So there is evidence that's something that should be offered. Mm-hmm. But if people actually have a psychosis, if you come to have a psychosis, the problem is that the evidence base consists only of drug trials of antipsychotic medicines, and the use of CBT and family intervention has always been an adjuvant to the use of medicines. So actually what research there is has always been through using a medicine and a family intervention and CBT. So the evidence base for using family intervention and CBT with antipsychotic medicines is very impressive. There's undoubtedly a very important thing to offer to someone with a psychosis where you're considering use of a medicine, but we don't have enough curiosity about whether we could actually provide a good service response without using medicines and just using CBT and family interventions. But what we did say in the guidance was that where a person and their family felt that they didn't want to use an antipsychotic medicine, that it was reasonable to offer a trial of family intervention and CBT, even though we don't as yet have an evidence base for it. But I think it's an example where we do need to explore these opportunities. Unfortunately, there's no pharmaceutical firm that markets family interventions or CBT.
And I also think things like making sure people are eating properly and doing physical activity and having meaningful occupation are really important as well.
Absolutely.
And they're not always very well funded either. Jackie, I was wondering if you wanted to comment on the kind of interventions that are involved in an early psychosis team, or that they might offer, and what your experience is in Australia, whether that's similar to what David's just said or different.
Look, I'd love to comment on that, because I think, Mary, there's a great deal of mythology out there, and perhaps perpetuated by bad practice in the past, or suboptimal practice perhaps. But really, there are multidisciplinary teams and multi-modal interventions are the key. Medications are not the only thing that is involved in treating a person. That is one component of a very large group of other treatments. And that's why the team is so important, whether that be someone being looked after in the public sort of mental health service or in the private sector. So family intervention is crucial for, and all young people who have got first episode psychosis should be receiving family support, family psychoeducation, family intervention to assist with their recovery process. All young people should get their own psychoeducation about their illness itself. Very frequently there's drug and alcohol intervention as well, and focus on reducing any comorbid drug and alcohol use, which can make the symptoms worse and recovery slower. Definitely, large involvement of what you were saying, meaningful lives, in terms of having something important, whether they go helping someone return to school or to find a job or maintain a job, assistance with socialising, leisure activities, and so on. And then, of course, the physical health care should be just embedded as core business within a first episode service. So what you referred to before, how to eat, what nutritional foods are beneficial in preventing someone to gain weight, physical activity, all of these things actually help someone in terms of both stopping people put on weight or preventing or reducing weight if someone has gained weight, but also to actually help someone's mental state. And there's more and more emerging evidence that exercise is actually influential in some of the hippocampal brain functions and actually may help with the symptoms of schizophrenia itself or psychosis itself. So it's very exciting, I think, that other modalities are important. Having said all of that, medications are important and can be life-saving in some people with psychosis. But I agree with David, it's not something we use unless someone has got a clear psychotic illness. There has been in the past misunderstanding about people with emerging mental health disorders just being given antipsychotic medications for no reason. That's not something that's good practice. So, for example, in the service where I work, there might be young people who get referred to us who have been prescribed an antipsychotic medication somewhere else, whether that be through an emergency department or through a general practitioner or private psychiatrist, and they've come to see us. We've done a more comprehensive assessment with a bit more time with different people involved, and actually found that the person doesn't have a first episode psychosis, so we take them off those medications and look for the other appropriate treatment. So whilst I am a supporter of using antipsychotics in the right situation, that is not what I would advocate, and I would really strongly recommend to general practitioners to resist the temptation to, which perhaps is something that pharmaceutical industry will promote at times, to use these medications off-label for other sorts of conditions. So it's not good for behavioural disturbance. It's not indicated. These medications are significantly risky in terms of side effects and should only be used for indicated conditions. So,
and Jackie, I guess I'm thinking about some of our audience, and many practitioners in Australia are working in either places where there is no early psychosis intervention team, and in many cases places where there's no psychiatrist at all. There might be a rural GP and a visiting psychologist. What kind of approach? Well, perhaps I might ask David, if you could imagine yourself in that situation, what do you think? How should we approach it? That may be unfair to ask, but
no,
not at all.
I mean, I suppose the tension here is that you almost need to feel quite excited about the opportunities. If someone comes in with an emerging psychosis, actually, it's one of your best opportunities for altering the trajectory of what's potentially a devastating illness. So there's part of me which thinks, that whoever's actually, in a position to manage and manage the care, it's very important indeed to get it right early on. And that's in a way the biggest challenge, because if, as a generalist, I'm a generalist, and to expect me to provide specialism, we don't remove appendixes, we don't take out people's thyroids anymore as GPs. We used to. As a generalist, you're expecting me to offer a high level of specialism here, because it's such an important opportunity to get it right at this stage, and also that I was very much trained in sort of very simple biological approaches. So medicines and the thoughts of using psychological therapies and family interventions would be way off my radar. It's not my training. And yet here's a situation where the evidence is really very, very strong indeed that well-applied interventions of that sort really early on will alter the long-term trajectory. So there's a lot at stake here. I guess I'd want to have Jackie on the phone. I'd want to be able to pick up a phone and first of all say, I'm concerned, I don't know what's going on, I'd like someone I can talk this through very clearly with. And then I'd like to be given some help and guidance on how I can produce a sort of a team approach around this individual, how you cluster the right sort of approaches around that individual. Because I'm certainly not going to be able to give the CBT or the family interventions. I certainly will need access to people who can do that. It's my role to be a care. I suppose I would be the care coordinator. I would very much be a central coordinator of the care, but I would need to have the expertise around it that would produce the sort of interventions that we know work. So that's what I think I'd be starting off as a GP. But I would want to feel excited about this. I would want to feel this is something we can do something about. And there may be advantages. There may be advantages to being, in a situation where you do know everything. You do, the community is small, and you can wrap around support around an individual. So there may be opportunities to do things which you might struggle to do in a more, the sort of areas where I've worked as a GP. So maybe there are opportunities in this too.
And I guess, what is available varies in geographical areas in Australia, and our early psychosis teams tend to be state funded, so that can make differences in different states. Jackie, I was just wondering, for example, would your service provide advice like that to a rural or remote practitioner ringing up concerned about a young person, whether they were a GP or allied health or anybody?
Well, at the moment, that's not something that's routinely done, but I know that there is an intention with the hopeful additional funding that is looking at and the restructuring of the state services with the early intervention in mind. I think there's an opportunity for teleconferencing and some more formal networks to be developed. So I know that is something that's on the agenda in terms of at least, in my jurisdiction in New South Wales. But I think there's a lot further we can go with that, and I think rural GPs and, we should all be having dialogues about how that could be actually facilitated. I do think that's very critical because, as David says, in general practice, it's not very common to see someone with a first episode psychosis. But the same within mental health services. I think, it's been pretty clear that specialist mental health services in this area actually have the expertise because they're seeing more and more of these types of cases. There seems to be a critical number that you need to see per year to make a service effective, apparently. So, but having said that, we need to have a good system where there can be phone-ins. So,
I guess the other thing I would want to add is the point about medicines.
Sure.
So, as a GP working in a rural area, it's absolutely critical that you get the medicines issues correct, get it right. When we start to prescribe antipsychotics, then it goes with the territories that metabolic changes occur, and they occur really fast. So within a few weeks, particularly on some of the second generation antipsychotics, like say olanzapine, the average weight gain after 12 months of olanzapine, 86% of people taking olanzapine within 12 months have gained 7% of the body weight. It's a colossal increase. And of course, weight gain is the thing that drives the other metabolic changes that do happen to this population. So, if I'm seeing a patient as a rural GP, perhaps once every 2 or 3 years, and I'm in a position of prescribing a drug to an 18-year-old or a 20-year-old with a lifetime ahead of them, and the risk is that I can actually create metabolic complication that by the time this young person gets to mid-30s, is running the risk that someone 20 years older would be getting. Their obesity, their type 2 diabetes, their risk of, the risk of heart disease and the risk of diabetes is develops quite rapidly, and it starts within weeks of starting antipsychotic meds. So I think advice on prescribing is really critical, and I would look to Jackie. I would definitely want to have a hotline to Jackie to say, what do I do? How do I manage this medicine? What are the things I should be monitoring? What is the advice I should be giving the person and the family? How do I help that person to make an informed decision about, weighing the trade-offs between the symptom control and the physical risks are things that people should be able to hear and discuss and talk about.
And I guess there are possibilities within the sort of Medicare system within Australia. So there's some telepsychiatry possibilities have recently come online, and I hope that we might have some psychiatrists who do specialise in early intervention become available in that way for rural practitioners. We often do have some allied health in our town, so we may have social workers, psychologists, OTs, and one of the other things that I think would be really useful for this group is the mental health nurse incentive program. So there was for a while, and hopefully will be again, funding for credentialed mental health nurses to work alongside GPs, and I think that they are often ideal to be involved in this kind of situation in primary care and acting in that case management type role and being able to assist the young person and the family and make sure that the communication happens between the different people.
Can I just make one comment?
Yeah, Jackie.
Ferry. I mean, obviously, trying to have access to live, assistance and expert advice is the ideal thing. But in the meanwhile, there's some really useful resources that I think would, every GP should have, and wherever they are. And one of those is the Early Psychosis Australian Clinical Guidelines, because they've just been revised recently, and they've got lovely flowcharts, just like a single page on what to do if someone has a first episode psychosis. Here's the sort of recommended medications and doses, and if they don't respond, here's what you do next. So one guide is for a psychosis-like condition, another one is for a manic presentation, and a separate one for depression. So they're single pages within this Australian Clinical Guidelines. So I think that's really worthwhile. The other thing that I feel obliged to promote is the role of GPs and primary care for clinicians in general, including the practice nurses, in the physical health screening. So regardless of where the person's getting their primary mental health care from, whether it be in a specialist service or not, the GP is in the central position to actually look after the physical health and actually be the coordinator of that aspect, which is critical. As David's saying, the most likely reason that people die from psychosis-related conditions is actually cardiovascular disease, not suicide. We pay a lot of attention to suicide risk assessment, but we pay less attention to physical health monitoring. So I think everyone should be feeling like positive about that in terms of it's a great form of engagement for GPs, and having some sort of screening tool so that you're actually looking for those cardiovascular risk factors and measuring weight and height and waist circumference and blood pressure and lipids, glucose regularly, and then actually intervening. So not just screening, but intervening and actually working out what the protocol should be for that. So again, there are guidelines that we've developed, and David has developed in the UK, looking at specific simple strategies for all clinicians, general practitioners or any other clinicians, for the management of these cardiometabolic complications. So
we'll be able to put up links to those guidelines, Jackie, and any other resources that we discussed. I know that in Queensland there's been a big project called Activate Mind and Body, which is exactly around this issue, and some resources, including a one-page just check sheet for GPs, have been developed that are quite practical and useful, and we can also put up the links to those.
A wonderful project, Mary, that you're referring to, and I certainly have used that and looked at that as well. There's some wonderful joint resources there for GPs and for mental health clinicians. New South Wales Health have done something similar, and we've been sharing those resources, and Western Australia has as well. I think we're moving along with that, and it's very positive that those resources are out there as long as they're being used.
And I suppose the other thing is for GPs to keep in mind, and for any allied health clinicians working with these young people, to remind their GP, we can consider an enduring mental illness as a chronic disease, and the patient will qualify for a GP management plan and team care arrangement, which then means that we may be able to involve a dietitian and an exercise physiologist. So we can really build a good primary care team if we think of it and we communicate with each other.
That's fascinating, Mary, because you putting me in the situation of being a rural GP. The bit we haven't really talked about, well, we have talked a little bit about, is the physical health issues. And if ever there was an issue that I, as a GP or with a practice nurse, should be competent on, we're probably the best resource around for that. It's interesting to speculate, why is it that we don't see ourselves? There's another quote from Helen Lester that I gave you earlier on, Can you just read out that quote?
Yeah, sure. It says, "I know that I can't look after people with severe and enduring mental health problems. I don't have the skills or the knowledge. I couldn't do it well."
And, I think it's interesting to tease into that. I think if you tease into that, there's certainly something about confidence. There may be something about stigma and discrimination going on there. It's quite a sensitive issue. But the end result is that that GP does not see themselves as someone who's got anything to offer, and yet the sort of physical health consequences are precisely the sort of things that we should feel confident to offer. And I think it's that feeling that, well, because this person's got a severe mental illness, I'm no longer able to offer them the ability to avoid cardiovascular disease and diabetes. Now, come on, that's our bread and butter. Particularly in England, it would be the bread and butter of our practice nurses, but they have no, the practice nurses have no training, and they're very anxious and nervous of dealing with people who've got a psychiatric label on them, but they wouldn't think anything of dealing with a patient with diabetes or with heart disease. The issues are the same. So I think there's a huge opportunity for primary care to offer something very special. A lot of psychiatrists feel nervous of dealing with the physical health issues, and we've just done an audit of screening and monitoring. I've been part of a big national audit for people who've got established schizophrenia, and the results they're disgraceful. They're shameful. This population with established illness, about 30% have an adequate cardiovascular screen, the standard things within the previous 12 months. Only almost 50% had not had a blood glucose measured. 50% hadn't had the weight measured in the last 12 months. Even though it's very high, this is a group with very high, rates of diabetes and so on. So that's a failure of me as a GP, and it's a failure of Jackie's colleagues as psychiatrists. We haven't worked out our respective responsibilities.
And I guess the other thing that comes from that quote, David, is that in fact, on their own, this GP couldn't do it well, and none of us can. But the point is that we actually need to be involving a collaborative team approach, and that's what the early psychosis intervention teams are. They're a team, and no one practitioner or one discipline is able to do all of this. And so it is actually one place where we really, really need to be working together.
Are we part of that team?
Yes, that's right. And I guess I happened to be reading the Exercise Physiologists industry magazine a couple of weeks ago, the Exercise and Exercise Science Association, I think they're called, and that they had 2 articles on mental health, and they're recognising it as being something which they should increasingly be upskilling in and assertively becoming involved in. And I found that really encouraging. I'm just mindful that we've nearly come to the end of our time. So I just perhaps would like to offer both of you just a couple of minutes to sum up anything that you think is particularly important for the practitioners listening tonight to take away from this conversation. Maybe start with you, Jackie.
Well, you practically summarised what I would have liked to have said, which is collaborative care, which is actually, I know the topic of this and the MHPN sort of motto, but it's actually very true for young people with complex psychosis, first episode psychosis, or those with emerging mental health disorders. It's not a one-person job. There's a whole range of issues that need to be dealt with, and that's best done in a collaborative care approach. So, I urge all of you to think that way about these young people, and also just to maintain your optimism about thinking about this client group, because perhaps we've had a pessimism in the past about this terrible diagnosis of psychosis, and it can certainly, devastate young people's lives and their families. But I think nowadays there's been a shift around to some much more optimistic approaches, and the collaborative care aspect is very much one of those things. And I would do a plug for those exercise physiologists, because I think it's one of our colleagues who might have written that paper that you saw in the Exercise Physiology Journal, and we're working very closely with exercise physiologists at the moment and students who have been one of the wonderful added collaborative team members in our armamentarium of actually helping young people with psychosis. So I think everyone's doing a great job trying to look after these young people and maintain your optimism, because I think we can make a big difference together. So thank you.
Thanks, Jackie. David, what would you like to tell us in Australia?
Well, it's the optimism word, funny enough. I think, we talked about early detection and how you how you pick up these problems early. The evidence is very, very impressive, really, that if we do intervene early in the right ways, then we do alter trajectories. And of course, probably the thing that drives our referral behaviours most of all is our internal optimism. If we feel pessimistic about what's likely to happen, then that switches off our behaviours. We switch off our clinical behaviours. So I think we need to be thinking. We need to understand the evidence, but we do need to look very, very closely at our own feelings and how we regard people coming in with psychosis. Are we actually discriminating in terms of them having a mental illness? Are we offering a pervasive sort of pessimism? So that I think the attitude is very important. And I think also this, coming back to the physical health thing, with the knowledge that these changes take place very early, then we have a real opportunity to be part of this team. And we have our own expertise. We're not psychologists and we're not exercise physiologists and we're not psychiatrists, but we do have expertise in terms of physical health care. So if people with a major mental illness get removed from my radar because they enter a mental health system and stay in it for several years and then eventually come out of it, then it's not surprising that I sort of don't pick this, they become disconnected from me. So I suppose I'd put in a big plea for services like Jackie's that you continue to link and integrate. I don't discharge people from my care. They're in my care potentially for as many years as they wish to be in my care for. So we're in it for the long term. So I think it's very important that I get feedback, that I feel part of the team, even in the very early phases. That psychiatry does take great care to keep me connected and communicate with me. Yeah, so that would be my message. Keep us involved, and we have a task of becoming more optimistic about this condition.
Thank you both very much. I think it's been a really interesting conversation, and I hope that there's been some useful things in there for the audience as well. The links to the resources mentioned will be available on the MHPN website alongside the podcast once that's been finalised. So I'd like to thank you both very much for your contribution. And David, I hope you enjoy the rest of your time in Australia, and both of you enjoy the themed Summer Forum.
Great. Thank you very much, Mary.